So thanks everyone for coming. We've got a tight schedule for time, so we'll have each of our speakers come up if there's time for 1 to 2 questions after each speaker. We can get to it then. Otherwise, other questions we might have to hold to the discussion at the end of the group. But thank you all for being here. It's exciting to see so many people interested in TB in adolescents. We're going to talk about some issues related to the scope of the epidemic and also some management challenges in the context of both drug-susceptible, drug-resistant TB, and also with HIV co-infection. And we've got a lot of interesting perspectives for the day. So we'll start off with Catherine Snow from University of Melbourne, and she'll be talking about the epidemiology of TB in adolescents.
Hi guys, how's everybody going? So I'm going to start off with some really kind of broad overview stuff, and actually with quite a bit of historical data from the UK that I felt was, geographically appropriate. And then I'm going to get into some work that we've done as systematic review of published prevalence estimates, and then our own statistical work on estimating incidence among adolescents. So there's a couple of things that I wanted to highlight as background for sort of understanding the context of adolescent TB. One of them is something that I think people who live and work predominantly in high-income countries are often unaware of, which is the huge proportion of the population in TB endemic areas that is made up by children, adolescents, and young people. So what this figure shows is the proportion by WHO region, and you can see that people under 25 are over 60% of the population in the African region. They're around 55% of the population in the Eastern Mediterranean region, which is the region that's dominated by Pakistan, and almost 50% of the population in the Southeast Asian region, which is the region dominated by India. Adolescents themselves are sort of 20 to 25% of the population of countries in these regions, and we think that there are around 2 billion adolescents living in the world today. With declining child mortality and also increasing access to contraception, many demographers feel that we're now at what one of my supervisors refers to as peak youth, which is that the current generation of young people are quite likely to be the largest that the world ever sees. The second thing that I wanted to highlight is something that actually even I didn't appreciate until last year, which is just how deceptive TB surveillance data can be when it comes to understanding how TB risk changes throughout our lives. So the figure on the left here is from historical surveillance data in the UK, organised the way that we traditionally see TB surveillance data organised, which is by time period, so in cross-sections. And these curves will be really familiar to any of you who work with TB surveillance data, and when you look at them, you get the impression that the peak period of TB risk for all of us is sort of in middle age, kind of around age 40 or age 50. What happens when you organise that same data by birth cohort rather than cross-sectionally is that you actually see what happens to the risk that generations face as they age, and consequently the risk that individual people face as they age. And so what that figure on the right shows much more clearly is firstly the astonishing increase in risk that people face between sort of age 10 and age 25. You see these lines that come up from age 10 at like a 70-degree angle. Right, this incredible increase in risk. And what you see, secondly, is that actually the peak period of risk in the lifetime of most generations is actually much earlier than we tend to think. And it's actually sort of between age 20 and age 40 for most generations. Now, with regard to that increase in risk, I've had a lot of very interesting discussions over the last few years about why that increase happens. I think there's probably quite a few factors that play a role, and I've had some lively debates about which ones are more or less important. One of the ones that I think is absolutely key is that adolescents, unlike young children, do develop infectious TB, with significant regularity. And that means that unlike, sort of children under 5 who might be in kindergarten, adolescents are actually likely to transmit TB to one another. On top of that, adolescents are spending much more time outside the home than younger children do in general. So they're attending school where they may be in quite large classes and in classrooms that are quite poorly ventilated often. And on top of that, adolescents socialise a lot. Most of us in the room will be aware that our social lives are less interesting now than they were when we were 18. And so when you put those factors together, it's not hard to understand that adolescents probably have a lot more respiratory contacts on a daily basis than adults do. And then finally, and this is one of the really contentious topics, is whether there may actually be a biological factor to this, whether adolescents might be at increased risk of progression to disease after infection. There's some very old historical data from Comstock that did suggest this, that the risk of progression sort of between age 10 and age 15 does increase. And I know that Marcel Baer's group in Canada have also seen this in an outbreak investigation that they did. Colleagues of ours in Melbourne in Australia didn't see the same thing in a project that they've done. So that one is more of a sort of live issue as to whether that occurs. But one way or another, you know, the period between age 10 and age 24 is this huge period of increase in risk. One other thing that I wanted to highlight in terms of background is how different the age-related epidemiology of TB is for men and women. So this is the same historical data from the UK again, but this time split up by sex, and it's still by generations or by birth cohorts. And what you can see here is that the age of peak risk of TB is quite a bit lower for women than it is for men. And we suspect that this could be partly related to pregnancy, and it's likely that there are also lifestyle and occupational risk factors for men that keep risk high for men later into life. But I think what this graph shows is that adolescence and early adulthood are really very significant periods for TB in the lives of women. So that's kind of the historical epidemiological background of adolescent TB, and now I'm going to present a few harder figures. So a couple of years ago, we did a systematic review, which is currently under consideration for publication. We identified 24 studies, mostly published estimates of TB prevalence, about a dozen of which were from national prevalence surveys. And these are the results from those national studies. You can see that the Asian countries are much better represented than the African countries, but this is going to change in the next few years as there are quite a lot more African countries undertaking prevalence surveys at the moment. And you can see that Pakistan, Nigeria and Ethiopia all have really quite high TB prevalence among their 15 to 24-year-old age group. And those countries also probably have quite a big case load because they're very large countries and they have quite young populations. So that's prevalence, and there's quite a bit more to do about prevalence and duration of disease in young people and that issue. And that's a little bit harder to do because the data are more difficult to get. You'll probably be aware that WHO estimate incidence from TB surveillance data, and that's something that's much sort of more advanced and more comprehensively recorded. And so we've been working with WHO over the last couple of years to develop age-specific incidence estimates for this age group. We presented very preliminary versions of these estimates in Barcelona a couple of years ago. I've updated them actually just last week to account for WHO's latest revision upwards, and the methodology has also changed quite a lot since we presented in Barcelona. So where we are currently, we estimate that there are about 2.2 million cases of TB among the adolescent and young adult age group each year. Most of those cases are in the 20 to 24 age group, which again reflects that huge increase in risk during this adolescent period. And you can see the majority of the burden is in the African region and the Southeast Asian region. And that reflects not only the very large TB burden in those regions in general, but also the young age structure of those populations. The Western Pacific region on the end there obviously also has a very large population and a very high TB burden, but they have an older population, and so the adolescents and young adults are not as heavily affected there. So that's the summary. So adolescence is a period of an extreme increase in risk for TB, and there's quite a substantial burden of disease in this age group currently. And some of you may have noticed that in this talk I've only discussed drug-sensitive TB. I haven't presented global data for MDR TB in adolescents and young people, and I haven't presented data for TB HIV in adolescents and young people, and that's because those data do not currently exist at the global level. And so that's an obvious sort of area for further work and enhanced surveillance. But we'll be hearing about those topics from a clinical perspective, at least for the coming speakers. Finally, I want to acknowledge my fantastic supervisory team who have been very supportive over the past couple of years of this work, and our collaborators at WHO who have been immensely helpful and very welcoming as well, and of course the people who paid for all of this work. Thanks.
I think I'll just add a couple of comments, Catherine. I think one thing that you pointed out about the age-related increase in TB prevalence at different age groups. So you think about the risk of women who are becoming mothers around young adulthood. This, links to the life cycle of a life cycle perspective of TB, that these are young women who may be having children. There may be risk there to the young children if they're not recognized as having TB. And then the other thing you mentioned, that there were more data coming from African countries regarding prevalence among adolescents. And I think the CDC recently did a study in Western Kenya where they saw roughly 600 per 100,000 prevalence of TB in adolescents who are in school, so not including those who might be out of school or street youth. So that's over twice the prevalence for the country. So I think with increasing data, we'll learn more about the risks and the prevalence in adolescents. I think we have time for one or two questions.
Could you come to the mic, Jen? They're recording the session, so. No, you're all right. Just for the audience at home, such as they are.
I wanted to thank you really for a fascinating and I think really important presentation. I think in TB we suffer so much because, we don't, our patients do, because of the way that ages are set up. But I was really disturbed to hear that nobody on a global level is collecting data on drug-resistant TB in adolescents or on HIV TB in adolescents. And why do you think that is, and what can we do to change that? Thank you.
So those data are collected, but they're not age disaggregated in the same way that drug-sensitive TB data are disaggregated. The issue there is really about the reporting burden for countries. So national TB programs and health departments in endemic countries have a huge burden of reporting to WHO and the other UN agencies, and any changes take a very long time to be implemented, particularly for countries that are still using paper-based systems. I think that's going to change a lot in the next few years, though. More and more countries are moving to case-based electronic surveillance systems, even in endemic settings. And I think once that happens, it's going to be so much easier for countries to do their own analysis and also to provide, more detailed disaggregated data to WHO. So I think that's a situation that will change in the near future, and there's a lot of really positive movement. But it is a slow process, and we have to give countries time to build up that capacity.
Yeah, thanks very much. Steve Graham from Melbourne and the Union. Catherine, great talk. If I could ask you, or just highlight something your co-chair pointed out in that study in Kenya that you're referring to. As I recall, they found a prevalence that was probably 5 to 6 times higher than what was actually being notified in that age group. And that struck me quite a lot. And I think we recognise for adolescents, particularly in low and middle income settings, the structures in place in the health systems for access to get diagnosis and everything. It is really a challenging age group because they do fall between the cracks, I think. But I just wanted to highlight, maybe you have more insight on those findings. There was a big gap between what was found and what's actually being notified.
Yeah. I think, that's something WHO have looked at a little bit in the prevalence surveys, but it's hard with the number of cases that they find. But yeah, we've got data from Indonesia as well to suggest, as you know, that the reporting rates for children certainly are absolutely abysmal in some settings. And whether that's also true of adolescents is really an open question at this point, but it's certainly very possible with that, falling between child and adult health services, that adolescents are disproportionately underrepresented in surveillance data. It's quite possible. It's that time.
Yeah, I think we're on track to move on. And we have Petros Isakidis, who will be speaking about drug-resistant TB in adolescents and interventions to improve outcomes in drug-resistant TB. And he's from MSF, formerly based in Mumbai and now in Cape Town.
Any idea how to move to the next?
Oh, is it, Catherine? How do we advance?
Oh, you should just be able to... No. Oh, one moment. The gentleman is asking for. They've got to queue it up manually up the back, so it may take a second.
I could comment further, though, on the study from Western Kenya. We do know that there's significant problems with the TB reporting that we've seen. Looking at the data from the AMPATH program, we know that there's cases that are bacteriologically confirmed TB who don't make it necessarily into the TB register. So there's probably some wide-scale problems as there are in other settings. But could lead to problems if we're not picking up on these adolescents who are potentially infectious.
Okay, so can I start? Yeah. Good afternoon. I'm going to share over the next 10 to 15 minutes some of programmatic experiences from MSF and others from around the globe. And I will share with you some case studies, some very raw data from programs of MSF and others around the world, and some also new data on new drugs and how adolescents are enrolled in this with new drugs. So I will start with Sarita. She's a 15-year-old girl. She was a 15-year-old girl co-infected with HIV and DRTB. And she was followed up in our clinic in Mumbai in 2012. 3 weeks before her treatment was about to finish, she denied to take any more drugs. She declined any more drugs, even though she had minimal, let's say, adverse events, and she was responding clinically well. We knew that she was coming from a very problematic family environment with sexual abuse and family problems, that her sister, also co-infected, had died a bit earlier. And she had a partner that she didn't want to disclose her status to. She was convinced to have a couple counseling. We hope that she will go back to her treatment. Eventually, she stopped even her antiretroviral treatment, and as we learned, she died a few months later. And we looked at our very little cohort of, at that moment, was approximately 50 to 60 patients with drug-resistant TB and HIV co-infection in Mumbai. And we identified 11 adolescents at that moment. And we had, as you can see in this flow chart, 3 died before we even started treatment. And then when we looked at the outcomes, positive were only 1, plus the 3 that were on treatment at the moment of this analysis. 4 adolescents had favorable outcomes, and 7 of them died. This was a quite traumatic experience for our program. We actually published this paper with these 11 adolescents. It was a debate whether we should go out and tell the people. There were even concerns in our team, some clinicians saying, "Are you sure, Petros, we want to go out and show how bad clinicians were, and we cannot handle this small group of patients." We learned that adolescents with co-infection die early, and we need to be fast in our diagnosis and in treatment initiation. We also learned the bad way that loss of follow-up can occur anytime, even when patients are about to complete the treatment. And also, of course, we learned that adolescents are different and are not kids and are not adults, and we have to have specific tools and tailor our program to address their needs. And of course, I think now Catherine showed us that, when we look at data, you see that younger teenagers, 10 to 15 years old, are grouped with kids, and then you have the older teenagers, 15 to 19, which are grouped with adults and elder people. And very often we felt that the adolescent story was actually never told. And then Manisa, a few years later, 18-year-old girl, co-infected also, coming from an orphanage. And she was diagnosed during an active case finding because of an outbreak in this orphanage for HIV-infected girls. Manisa's first problem was not the disease, the diagnosis, or the prospects of treatment for 2 years, but was that she would be isolated in a room in this orphanage, that she would not go to school. She was stressed that she may lose her school, and that she also missed her exams. Our patient support team said that she was a very interactive girl and very open, but she was also moody, and her attitude was unpredictable, which required frequent sessions with our support team. But Manisa was a lucky girl, and she tolerated very well the treatment. She had some moderate adverse events, which our clinical team aggressively addressed. They changed paths for linezolid and clofazimine to address her nausea and vomiting. And she successfully completed her treatment, and she interviewed for a job in a call center in Mumbai and got her job. And what we learned from the success story after Sarita's sad story was that in case of Manisa, what we think helped her to complete her treatment was that, first of all, she was diagnosed earlier. As I said, it was active case finding in this orphanage where the outbreak was there. We put her on treatment early. We aggressively managed her adverse events. We think that also the orphanage and with our support did a good job by having a nice isolation room with a lot of activities for her. A personal tutor was provided for her, so she felt good that she can follow with her studies. When she was feeling good, we could bring her out for picnics and celebrations and go to the movies, etc. And I think our patient support team did a good job by providing a tailored to her needs sessions with frequent visits, and we even for the first time employed a peer supporter, an adolescent who had completed treatment before, and she was involved in her care. And I think the big thing that we learned that we should not only discuss treatment goals and conversion of culture, but we should have our ears open to their life goals for this space. And I think for everybody, not only for adolescents, also for adults and for everybody. So a few years later, our colleagues from Kailicha, South Africa, published also their data with outcomes of drug-resistant TB patients, some of them co-infected from Cape Town. Not very encouraging outcomes, actually, quite poor outcomes. Again, high loss to follow-up rates. And here I'm apologizing for this table with raw data. In fact, we wanted to pull and we sent a request around MSF projects and some other partners, like our colleagues from Harvard in Peru, to share their data. And they all responded and were thankful, but they sent a little bit the last moment their data, so there was no time to look at it more carefully and with different definitions, etc. I just want to share with you some small figures, and with looking mostly at Kailicha's data, which are final outcomes among 70 adolescents with MDR-TB, and also looking at the Harvard data. And as you can see, the success rates among these co-infected adolescents, not all of them co-infected, 31 in Kailicha, were 45.8, much better than was previously reported by them, 25% success rate. But if you look at the Harvard cohort of 90 adolescents, with 1% of them co-infected, an impressive success rate of 75.5. I would like also to draw your attention to the death and loss to follow-up in Mumbai, because we have a good tracing system for patients with a loss to follow-up. We were more able to ascertain more deaths, 15/4. Our colleagues in Kailicha report more loss to follow-up than deaths, 25 and 6. Again, these are very raw data. I hope that we will try to pull them together and standardize the definitions and look at adolescents, but at the outcomes more carefully. But I think what is interesting is that we see that maybe the situation is not as bad as we thought. And over the next few minutes, I'm gonna discuss what is already published from some interesting papers. Again, a very small slide just showing some smaller cohorts in MSF, small numbers always, Kenya 16, 3 from PNG, 10 from Abkhazia, and 2 from Cambodia. I don't think these are interpretable. It's just to show that at least we have some movement that we're gonna start pulling our data together and discussing the adolescents separately from the rest of our patients. So I think just repeating again and again, and sorry for that, that the data on adolescents are quite limited, and we heard Catherine saw also before. The existing data, especially in the beginning, showed quite poor outcomes. However, we need to look more carefully at that. Maybe the situation is not that bad. We saw a lot of loss to follow-up that may mask high mortality. The effect of HIV co-infection, I think, should be more carefully discussed, analyzed, and modeled for. The effect of baseline severity of disease was something that most of us didn't look at. And of course, there are differences between drug-resistant TB and susceptible TB, as you all know. And this very interesting paper, which was published a few months ago in Clinical Infectious Diseases, a Peruvian cohort of children, but they looked carefully at their adolescents within their cohort, the 10, 15 years old at least, that are within the children. And when they adjusted for AIDS, they found that disease severity actually was associated with death and treatment failure. So they didn't really find adolescents being a risk factor. And when they looked for loss to follow-up also, they couldn't identify significant factor, statistically significant risk factors for follow-up. The hypothesis in this paper was that actually the greater delays in diagnosis and treatment, maybe among older adolescents, was the reason for the previously reported high loss to follow-up rate. Some immune things like Catherine was discussed a bit briefly before, and of course they repeat the same again and again, that the data are so limited to allow for conclusions. A paper that I really liked, Leslie, was published just very recently from adolescents in Botswana, and I particularly loved that Leslie and her colleagues looked at, compared adolescents with youth and adults. They found that the loss to follow-up was significantly higher among adolescents, 10.8 versus 7.6 and 5.5 among youth and adults respectively. And also when they looked at factors associated with loss to follow-up, adolescents came as a significant factor. The odds you can see there was 3, and also HIV status being positive, the odds were 2.2 for loss to follow-up, and extrapulmonary disease also significantly associated with. And I'm gonna finish about the new drugs. And you all know that we have the bedaquiline and delamanid being used. And here I have to thank people, the Jennifer and Vivian and Sylvie, the two Jennifer and Vivian from the DRTB stat, which collect programmatic data on the use of these new drugs. And here is a kind of summary of what is currently on the ground. 5,700 plus patients on bedaquiline under program conditions right now, 17 children and adolescents. Most of them are adolescents for, as you know, the bedaquiline is not used in children. Delamanid, 25 out of 405, quite abysmal figures. And there are 3 adolescents on a combination of bedaquiline and delamanid. And again, very recently this year, earlier, a paper was published in ERJ on the new drugs on compassionate use. This is about delamanid. 19 patients, 13 was treated by my colleagues around the world, and 17 of them were on delamanid. The interim treatment outcomes were quite good, 81.2 culture negative, converted culture, and quite well tolerated, 18 out of 19 with no adverse events. And just to go a little back to share with you, this 25 actually, it's a bit of a sad number. Yesterday we were sitting with Jennifer and with Sylvie, and we were head counting how many children and adolescents are on delamanid right now. And considering the needs, we felt quite sad that we can identify the kid one by one and adolescent where they are and by whom they are being treated. So I will finish my presentation with the last case study with Sunita, who is she's a 14 years old girl, and she came to our clinic referred as a case of primary drug-resistant TB with and here DST was sad, or she was resistant to almost everything. She had a lymph node, cervical lymph node, and pulmonary and with pulmonary TB also. She's among the first patients on the combo, and she's also on imipenem. We couldn't design a regimen for her with adequate number of drugs. She's a very lucky girl to have a very supportive environment. Both her brother and her mother are her treatment buddies, and they make sure that she gets her ECGs and her cultures and her visits and her and keep the hygiene of the portacath every day, and she takes her pills. She has no adherence issues, she has no major adverse events, and the only unfortunate event in her course was that she had an infection through her portacath. She's now fine, she's doing well, and if you see her pictures, she looks so pretty and so better than when she first came to us. And I'm gonna finish with something that her counselor Pooja, which is not her age, but at least she's a young girl. She told me, Petros, if you talk to Sunita, she will not tell you that her problem is her disease, but she's bored at home and she cannot go to socialize in school, and she doesn't care only for the life skills that you're going to get at school, but the fact that she is not able to play with her and socialize with her peers. And I think I will finish here by thanking all these people from, especially Mubai and Kaelicha, the people from MSF, Gabriela, Kathy, Alex, the people, and Leslie for the invitation, and Vivian and Jennifer for sharing their DRTB stat data. And please go to Step Up for TB and sign for the governments to upgrade their testing and treatments. Thank you very much.
Right. Just to make a comment, obviously we're packing so much into these very quick talks, but you brought up the issue of adolescents needing to socialize and to have their normally developmentally appropriate socialization and peer interactions, and we'll hear a lot more about that when we hear from a former patient. Also, the issues of HIV and TB co-infection we'll get more to with Liz's talk. To speak about the what we found in Botswana with drug-susceptible TB, there was the risk of loss to follow-up that was associated with adolescents and with HIV positivity. But as far as treatment failure and deaths, adolescents did better than adults. So it really suggests that, at least for drug-susceptible TB, they may tolerate treatment quite well if we can work on the adherence and follow-up issues and all the things that we're going to get to as far as supporting the patients. So we're learning more with more data, as you said.
We actually don't have time for questions. We didn't want to stop Petros's amazing, interesting talk, but,
Yeah.
But at the end.
We will get to them in the discussion. So Liz Lowenthal comes from UPenn and Children's Hospital of Philadelphia, and she'll talk about adherence issues in adolescent TB and HIV treatment. Once
Thank
we
you.
get that queued up.
Well, while we're waiting for my slides, I'll tell you there we go. My conflicts of interest. I do have some research funding from Gilead Sciences, and my husband works for Otsuka Pharmaceuticals. I'm going to talk with you today a bit about the TB-HIV co-epidemic and what HIV has taught us and continues to teach us about adolescent adherence to medications. We're going to talk a little bit about the challenges that we face in supporting adherence in adolescents and how we might be able to use some of what we've learned in recent years about how their development impacts on their adherence in order to improve our interventions. So as many of you know, worldwide there was tremendous progress between 2005 and 2012 in how well people of all ages, when you put them together, were doing in regards to HIV-related deaths, with a decline of 30%. Do you all know what happened to adolescents during the same time? Deaths increased by 50%. And most of these deaths were occurring in Africa, and most HIV-related deaths in Africa are TB-related. So we've known for quite a few years now that adolescents do worse when they are HIV infected compared to both younger children and when compared to adults. These are some of the first data that were published related to adolescent outcomes from a paper by Jean Nishega in South Africa. And what you can see here is that even when you're only including those who achieved full virologic suppression, the rate of loss of virologic suppression is significantly faster among adolescents compared to older patients. We also know from other work done in South Africa that when patients are dually infected with both HIV and XDR-TB, that their adherence to their HIV treatment is actually better than their adherence to their TB treatment, which seems really counterintuitive when you consider that these patients should all be in DOT programs. But we know that DOT means different things in different places. And what this study showed was that after 6 months of treatment, almost 90% of patients had what was considered optimal adherence to their antiretroviral therapy. However, fewer than 70% had what was considered optimal adherence to their TB therapy. And this is the same patients. And exact same patients' adherence to 2 different regimens. Qualitative data from this cohort showed that stigma and isolation were big barriers to their adherence, and poor communication, which often manifested as getting good counseling when they first came in with their HIV infection about the importance of lifetime treatment, but not good enough counseling about the importance of maintaining adherence to their TB treatment even after they felt better. Also, patients' involvement, active involvement in their own therapy and their ability to communicate their needs to providers were problematic. Now, put that need to communicate with adolescents, with any patients, in the context of adolescents who biologically are programmed to test boundaries. And I love this comic of the mouse. Mice should know, if they've been around mousetraps long enough, that they shouldn't go for that cheese. But the adolescent mouse says, I can totally get away with this. So you've already seen some of these data. Thank you, Petros, for letting me go through this quickly. I'm going to just very quickly highlight a little bit more from the study that Leslie led in Botswana, where we looked at a retrospective cohort of all adolescents who presented at 9 treatment centers in the capital, all of the youth, so 20 to 24-year-olds, and then 1 in 3 of the randomly selected adults. And Petros has already shown you this data in a different form, but what I want to highlight is that the adolescents were twice as likely to be lost to follow-up compared to adults, and that those adolescents who were HIV infected had a much higher rate of loss to follow-up compared even to their non-co-infected peers. So 23% of the co-infected adolescents were lost to follow-up compared to about 6% of the adults and the youth. And this multivariable model Petros also showed you, which showed that the adolescents had a 3-fold increased odds of having been lost to follow-up and being HIV infected and having extrapulmonary disease were also independent risk factors. So I'm now going to present you some data from the BANANA study, which is a study that is currently ongoing, but we've been following a cohort of 300 adolescents in antiretroviral therapy. So these are not TB co-infected patients. This is just to give you a sense of what HIV is teaching us about adolescence and adherence. And the questions that we focus on in this study are really trying to define who of these adolescents are at the highest risk of failure, and what are the developmental and behavioral characteristics that we can target in order to be able to treat them better. So at entry into the study, the patients had to be between 10 and less than 20 years of age, and each of the patients had a MEMS bottle on their medications, which lets us know every time they open up their medications to take a dose. And the team in Botswana is blinded to these data so that they're not able to give feedback to the adolescents if they're not opening their bottles. And we have a very strong relationship between virologic data and what we're seeing from the MEMS caps. So there are 2 things that we've learned from this study that I want to highlight to you in the little bit of time that we have left today. One of them is the increased risk that we see among the adolescents who come to clinic alone. And the other is the risk associated with psychological reactants, and I'll explain to you what that is in just a moment. So we hypothesized that routine clinic attendance without a parent would increase the risk of treatment failure, and we thought that this would be especially true among the younger adolescents compared to the older adolescents. We defined parent as any adult caregiver. We define virologic failure as having a viral load greater than 400, and we looked at the relative risk of virologic failure among those who did or did not have a parent present at both their 3- and 6-month follow-up visits. We used multivariable logistic regression to test for confounding and effect modification by sex, age, orphan status, and time on treatment. And what you can see here is that among those who had a parent present at both the 3 and 6 month time points, there was a 7.6% failure rate by 6 months, compared to a 25.5% failure rate among those who did not have a parent present at both of those time points. The relative risk of failure if a parent wasn't present was 4.5, and there was no confounding by sex, time on treatment, or orphan status. There was, however, confounding by age. And what surprised us was that it was not the younger kids who were coming alone who were at the highest risk. It was actually the oldest adolescents who were coming alone who had the highest risk. And you can see that those, if you look at the red line there, those who are close to 20 years of age had about a 60% risk of failure if they were coming without a caregiver. And if we have time, I can discuss some of the qualitative data to explain why we think that is. So who else is at higher risk? Many of you may have heard of psychological reactance, but I'm sure all of you are familiar with this phenomenon, which is the phenomenon by which adolescents do the opposite of what somebody, and this can happen to adults too, but it's particularly prominent in adolescents, that they do the opposite of what someone in authority is telling them to do because of the feeling that their autonomy or their freedom is being compromised by that individual. And my husband just walked in and is standing in the back. One day we were driving down the road in Philadelphia, and I said, "Wait, stop the car, I have to take this picture." And this young adolescent was sitting on these stairs, and you can see it says, "Do not sit on steps, do not sit on steps, do not sit on steps." And there she is. So she's testing a boundary because you can see she's on the step that doesn't have the sign. And she's also showing some reactance. So we became really aware of the need to worry about psychological reactance when we were doing some qualitative work with adolescents in Botswana who were struggling with taking their medicines. And this is a quote from a 17-year-old who'd been on treatment a long time who was explaining this phenomenon to us. And what she said was, "When my mom asks me to drink my pills, I feel angry. And then I open the bottles, I take the pills, but then I put them back in and I close the bottle and I don't take them. I pretend. But when it's my time to drink the pills, I drink them when nobody is asking me to drink." So further discussions with these adolescents showed us that this seemed to be a quite widespread phenomenon, and we were able to validate 2 questions in order to measure this in our longitudinal cohort. The 2 questions, which are measured on a 5-point Likert scale from definitely false for me to definitely true, is 1, when someone reminds me to take my medicines, it makes me want to not take them. And 2, I get angry when I'm reminded to take my medicines. So we had 285 adolescents who had reactance scores and 24 months of prior follow-up with the MEMSCAPs and virologic data. Of those 285 adolescents, 89 or 31% had reactance scores greater than 4, which was our cutoff for positive reactance. And the reactant adolescents had a 2.4-fold increased odds of virologic failure compared with the non-reactant adolescents. And you can see here that the more reactant they were, the more likely they were to fail, with those who said that they very frequently feel very strongly about both of those questions having failure rates of greater than 60%. So how do we strengthen adherence based on what these data have told us? My belief and what we're looking forward to now in our work is that we need to focus interventions not just on the adolescent, but on their entire support system, and that we need to work with adolescents to understand when they're feeling reactant and help them to negotiate their own solutions and their own support systems. So I'm going to stop there because Catherine's giving me the time, and hopefully we'll have time to discuss a little bit more later. Lots of people to thank.
Thanks, it was really good. Don't want to eat too much, particularly into Elle's time. What is the discussion time at the end? you raised a point that resonated with me. Helen Cox, when I saw her speak a few years ago, I think was commenting on that KZN study and made a point that really resonated with me, which was that with that issue of HIV versus TB therapy adherence, like she made the point that we often talk about like loss to follow-up. And she was like, well, they're not lost, they just don't want to take the medication. And I think that's really important when thinking about like adherence support for adolescents, that like interrogating them and saying, okay, well, why? You know, like what's wrong here? What is the reason for that refusal? And also in terms of data, something that I saw in the South African data is that there are kind of two big groups of adolescents. There are genuine losses to follow-up where the treatment outcome's not recorded and we actually don't know what happened to the adolescent. And then on top of that group, you've got people who are recorded as having actively left treatment and refused treatment. And it's really important to look at both of those groups in order to get a true estimate of the extent of the loss to follow-up. I think we've probably got time for one question from the audience if someone wants to come to the mic. Otherwise, we can go from the end. All right.
I'll just add, I think as Liz alluded to, it's developmentally appropriate for adolescents to be taking more control or wanting more autonomy and developing that. So as she said, you know, finding solutions where adolescents have more control over their treatment. And I think we'll get to that with the next couple of talks. We have Andrea Cruz, who's going to be speaking about social considerations. Thanks, Liz. Andrea Cruz from Baylor College of Medicine will be talking about social considerations and the care of the adolescent with TB. And as we said, we'll have to get to a lot of these really interesting points in the discussion afterwards.
Perfect. Thank you. Thank you, Liz, for being the only person I have to follow or have to adjust the mic upward. I try, Steve. So in the course of the next 10 minutes or so, we'll talk about why adolescents might fall into gaps in the existing systems, to talk about some problems that one should address with your patients up front, hopefully prior to them becoming problems, and then understand the burdens of substance use and abuse among adolescents. I think the adolescent conundrum has been well described by the prior speakers, but I think it gets to an issue that some of the features fall into features of adult TB and others of pediatric TB. But I think it gets to bigger issues as well. And I think it's a problem that as pediatricians, we're very comfortable taking care of young children. Most of us probably didn't go into pediatrics because we wanted to take care of that child sitting sullenly on the steps with a no step sign. Right? And then our internal medicine colleagues, although they fall often in many countries into the scenarios where they are taken care of by our internal medicine colleagues, while they're very comfortable taking care of many of the medical aspects of their care, they're very frustrated by the psychosocial immaturity of some of our adolescents. And following me is going to be a speaker who is probably more mature at 17 than I was at 25. So I don't think Ella is certainly representative of the vast majority of patients that I care for. So I say this with that caveat. I think many of the challenges that are medical have been covered by past speakers, so I'm really going to focus on the social aspects. I'm talking about stigma, about the role of mental health as it relates both to existing comorbidities that might become obvious when a child actually has access to care, as well as specific symptoms that might arise directly as a consequence of a child's TB treatment in isolation. The role of missing school and work, and then finally by substance use and abuse. So there's a lot of stigma in our kids, and actually we found even in our adolescents who have just TB infection, a lot of them have quite a bit of embarrassment over the need to take TB medications. But for the children who have disease, for adolescents with disease, there's the additional guilt of concern for infecting family members, friends, and classmates. In the United States, where we do extensive contact investigations, there's clearly a fear of de-identification when the health department goes out to their schools. And the reality is, despite the fact that our health departments, I think, do an amazing job trying to maintain privacy, the reality is that the classmates look for the kid who's been out of class for a couple weeks, and usually it's not very difficult to figure out who that person is. The ramifications of this are more than just that relate directly to the child's mental health, but we know that there's clearly a link between stigma, adherence, as Liz talked about, and concomitant use of other substances as patients attempt to self-medicate themselves. And in addition, there's some studies from more resource-poor settings that because of the stigma associated with TB, patients have a tendency, even when they have a pretty good idea this is the diagnosis, really attribute TB symptoms to other diseases. And this can lead to diagnostic and treatment delays in addition to adherence and prognostic issues. So how do you address this? So one of the things I talk about with all my adolescents is the role of social media. This is particularly the case when I have to literally pry the phone away from my adolescents prior to beginning conversing with them in the examination room. So we know that, at least in the United States, about 92% of adolescents go online daily, with roughly a quarter saying they're online almost constantly. And I can tell you this is certainly verified by their parents, who are driven absolutely crazy by this. Most use more than one social networking website, and the websites that they use are quite varied. I had one adolescent recently who, when I talked to them about sort of not posting his TB status on Facebook, for example, said, "Oh, doc, only people your age use Facebook." And I was like, oh. And then he talked to me about all the websites that I didn't know about that people his age use for social media. But you could see that many of our adolescents not only use social media, but use multiple social media platforms. I must admit I liked that adolescent far more before he made that comment. So we talk about messaging the community. So talking to them about, you post something on, Facebook, because I don't know any of these other social media sites. And even if you unpost it, if somebody's seen it in the interim, you really can't unpost it from their heads. And then facilitating return to school. So that's working with your local health departments to make sure that they're, promptly getting sequential sputum sampling so that they can clear the kid to return ASAP. From a mental health standpoint, these are studies that have been done outside the United States, but they found that depression was found in up to a quarter of young adults who had pulmonary TB, and PTSD was noted in up to 30% of young adults who had TB in South Africa. And both of these diagnoses were more common in patients who were co-infected. You will note that there is no adolescent-specific data on mental health as it relates to tuberculosis. So how does this have ramifications? So part of it relates to access to care. So in the United States, we have abysmal access to mental health services, and much of that access needs to be done by your primary care provider. And I find it very concerning when one of my patients in TB clinic, I say, "Who's your pediatrician?" They said, "You're my pediatrician." I'm like, "Oh, no. And so because of the gateway policy that we have, it's really difficult to get adolescents into care. And even when you do, and you get the psychiatrist over the hurdle of saying, "Hey, so I have this patient with pulmonary TB that I'd love to get into your clinic," and then they usually go running in the other direction. Then you have to worry about how antidepressants actually interact with your rifamycins, because we know the selective serotonin reuptake inhibitors, which at least in the US is the most common drug that we use to treat depression, certainly interacts with your rifamycins. What about missing school? We already talked about the need for sequential and rapid serial sputum sampling in the kids to get them back to school. And I will say that many of my patients are not exactly stellar academic performers at baseline. So these are really not kids who can afford to have prolonged school absences. So we try to help them with this once they're able to be clear to go back to school by scheduling appointments when the kids are on fall or spring breaks, trying to fit them in around the holidays, et cetera, so that they minimize time lost to school, particularly at the beginning and ending of the school year. And I'll end by talking about substance use and abuse. I couldn't find a lot of good data from many countries, but, and I don't know if this is simply because American kids are more prone, and Canadian kids, are more prone to bragging about their substance abuse, so maybe these are data that are a bit easier to acquire in North America. But we know that certainly ethanol use is incredibly common, with almost 3/4 of adolescents having drunk alcohol before they graduate. Of note, the drinking age in the US is 21. I don't know what it is. Is it 18 in the UK? And about 6 million US teens binge drink, which means drinking at least 5 drinks on more than one occasion once a month. We know that marijuana use is incredibly common, and something that is relatively less well described is actually the use and abuse of prescription drugs, namely not that child's medications. So I think it's foolhardy if you think that you're taking care of an adolescent population that is entirely innocuous when it comes to use of these substances rather. So the top is actually an actual text message or an email I got from a patient. So for those of you in the back who can't read, it says, "Excuse me, will you help? I'm taking TB meds." This gets back to my patients not being academic stellar performers when you look at the grammar here. And he says, "I know I can't drink, but can I smoke weed?" So on the one hand, I was very excited that he remembered that I told him he shouldn't drink alcohol. On the other hand, I wondered if he thought I was going to respond in email format, and something that was recordable, "I don't care if you smoke pot," right? And so I found a nice little yellow submarine bong here. So important to talk about patients about what is going to be more harmful to them if they're polysubstance abusers, and not respond in any kind of print format. This is a patient who sent me a text message. He says, again, the grammar is abysmal. These are not patients, both of these patients, English was actually their primary language. It is not a linguistic barrier. What happens if you're taking the pills for the TB and you do drugs like lean and dro just once? So apparently reflecting my age, I was like, what the hell is lean, right? So thank God for Google, which illustrated lean is a combination of Phenergan, codeine, Sprite, and Jolly Ranchers. I guess if you combine codeine, Sprite, and Jolly Ranchers, you probably actually do need an antiemetic in the cocktail. And then dro is hydroponically grown marijuana. So how do we address this? So again, interviewing the adolescent by themselves. They're not going to fess up to anything in front of mom. It's unrealistic to expect a polysubstance abuser to stop everything, right? If you think they're going to stop the 14 substances that they're using, it's not going to happen. So at least tell them what they can and cannot use safely. So I will have the conversation with the kids who smoke pot, saying, yes, I talked to them about this is probably not great for your long-term academic outcomes, et cetera, et cetera. But then I say, I'd really prefer you smoke a joint rather than using a bong while you still have cavities. So, try to mix in a little bit of infection control in there. And then these are kids I tend to see in clinic more frequently and do more frequent laboratory evaluation. I think on the pediatric side, for many of our otherwise healthy kids, we're a bit more cavalier about getting baseline screening labs, and if those look okay, we don't necessarily check sequential labs and the child is asymptomatic. But in this is a population which I certainly would check that. And I put this slide in here just for Tony, because he does pharmacokinetic stuff. So it turns out there actually is an interaction between cannabis and rifampin. But fortunately, from our standpoint, it's simply that the rifamycins reduce the effect of the cannabis. So they're probably going to need to smoke more pot or use more edibles. All right. On that note, I'll conclude by saying that the adolescents really do blur the line between pediatric and adult TB. And in contrast to the younger child, and I think many of the prior speakers, both Petros and Liz specifically, have spoken to this, is that they really need to be active participants in their own care and need to know what's in it for them. And what's in it for them and what's in it for us might be two different things, and how do you reconcile those two things? And finally, the importance of addressing potential problem areas at the start of therapy, hopefully trying to intervene before it actually becomes a problem. And with that, I'm happy to take a couple questions. Thank you.
So I'll make a couple of comments while if any speakers or if any people want to ask questions, you could come to the microphone. One, I think it's a credit to you that they ask you these questions about substances. I will say that we have done some qualitative work in Botswana that we're still analyzing, but we have seen from care providers in the TB clinics that also in that setting, substance abuse could be a potential problem. Was one of the first things that they mentioned as being a challenge in adolescence was kids drinking alcohol and smoking at a very young age. So I think, as you said, something to address proactively.
I think the only time I've had a patient, one of my adolescents, actually get mad at me was when I made him take out his nipple ring prior to getting a chest x-ray, because the nipple ring actually entirely overlapped the area he had a prior cavity. So he was very angry with me that day. So, yeah, Liz.
Thanks. I'm just wondering, Andrew, if you're aware of any social media sites that are supportive of adolescents with TB, whether there's a place where they can come together and share their experiences online. Because with some other diseases, those exist and have been shown to be helpful.
Liz, I haven't found much on it. I actually did go looking for social media groups that specifically related to TB, but I couldn't find any that were, and I did look mostly, I did what was Googleable, frankly. So I certainly might have missed something.
Do we have another question? I can go to the mic.
Hi, about protective factors for adolescent risk behavior. There's been a lot of work around that, and I wondered if you had any experience of promoting protective factors which prevent risk behavior. Mm-hmm. For example, family connectedness, then school connectedness, psychological autonomy, and the other thing was religiosity. These are the 4 protective factors that have been identified as, instead of studying risk factors, studying protective factors is quite productive and helps adolescents. So I wonder if you have any experience of using those protective factors in programs.
Yeah, no, it's a good question. So one of the things that we do encourage is that the adolescents don't come to clinic by themselves. That is made substantially easier in the United States, where kids can't sign for their own health care until they're really of age. They're 18 years of age, so almost always they're actually coming to clinic with their families. I offer to always call anybody who the adolescent wants me to call to explain TB to them, because sometimes the way that they explain it and the way that somebody else might explain it might be a bit different. And then hopefully that's one platform to potentially reduce the associated stigma with it. Most of our care is ambulatory care with only a handful of examples that I've had. So usually we are able to reintegrate the child into their communities pretty quickly. I think one of the problems that we run into, frankly, is that there's so many gaps in primary care access in the United States. And the majority of the kids who get TB are probably going to be the kids who lack primary care access. So a lot of times when they come to us, and we're often the first pediatrician that the kids have seen in years. So many of these risk behaviors have sort of already been established but have never been addressed at the time. For me, it's a question of risk reduction rather than risk elimination, because unfortunately for many of our kids, I don't think that we can ever fully eliminate the risk. It's an interesting question that you have regarding sort of the role of sort of faith in terms of this. And I think that's something that, I don't often talk to adolescents, or actually I don't talk to adolescents about that unless they bring it up. And I think that's very reflective of a culture that we have, that, that there's very much the separation between the science and then faith-based systems in the United States.
Thanks, Andrea. All right, we've got to move it on, and it's time for our last speaker,
Thank you.
who's Elle Frame.
Hi guys, I'm Elle and I'm 18 years old in my gap year, going to Edinburgh University next year to study international business. In February 2014, when I was 15 years old, I was diagnosed with pulmonary tuberculosis, and it actually took me a week and a half to be diagnosed. I started getting ill on the 14th of February, where I got coughs and night sweats and I didn't really have an appetite. And my parents thought, oh, her dad's got a chest infection, it's probably that. A week later, on the Tuesday, Mum said, oh, you're not getting better, let's take you to the doctors and see what they say. So I went to my local GP, they listened to my chest and they said, oh, you've got a little bit of crackling in your left lung, chest infection, take amoxicillin, you'll be fine in a few days. Normally, I started to feel better after the first couple of pills. However, that evening, I got a lot worse. So my mum said in the morning of the Wednesday, oh, just cough into the sink, let me see what you're coughing up. And this was what was terrifying. I coughed up big clumps of frothy red blood. There was no phlegm, it was just complete and utter blood. This went on for about 15 minutes before I could be moved from the sink, and my mum said, right, don't panic, we'll go to the hospital, see what they say. So up to the Whittington, which was my local hospital, and I went to the paediatric ward, and about 20 minutes later I was seen, and they again listened to my chest and said, oh, it's just a chest infection, keep taking your antibiotics, you'll be absolutely fine. However, my mum, who's quite on the ball with medication and illness, said, actually no, my cousin, who went to Indonesia and is Indonesian, was diagnosed with tuberculosis 18 months ago. Is there any way we can get my daughter tested? So they said, okay, fine, go for an x-ray, come back tomorrow. So I came back on the Thursday and they gave me a MAN2 and a sputum test. By this point, I was 40 kilos at the age of 15. I had immense back pain, so I couldn't actually move. I was still coughing up blood, and on the Wednesday, I coughed up a bit of my lung, which had been eaten out by the TB. So the Friday, I'm waking up and I look at my MAN2 and I think, oh, it's a bit swollen, I'll give my mum a call. So I call my mum, she says, oh, just go on the internet, look up what a really infected MAN2 looks like and you'll be fine. Go online, I see the horror stories and I think, yeah, I'm absolutely fine. It's just a chest infection, the doctor was right. However, Friday evening at around 7 o'clock, we're all sitting down to eat Chinese. I'm not really eating. My mum gets a phone call. 10 minutes later, she comes up to me saying, Eleanor, that was the Whittington. We have to go to the hospital. Your sputum is showing 2 signs of pulmonary tuberculosis, and we need to check it hasn't gone into your bones. So I go in, I have my MRI scan, and I'm waiting in the hospital, not allowed to leave my room because I'm on the paediatric ward, until 1:30 in the morning where they come in and say, don't worry, you're fine, you can go home, come in tomorrow for your antibiotics. I'm then on 12.5 pills for 1 month, and then 6.5 for the rest of my treatment. So while I was in the hospital that evening, they said, tomorrow you need to be tested for HIV and AIDS. I'm thinking, oh God, I don't want to have that. So I get tested and I get the all clear. So of course I'm infectious for a month, so I can't go to school. And I wasn't planning on telling people I had TB. I was just going to say, oh yeah, I was really ill with a cold or the flu. However, my English teacher decided to leave an email on one of these boards that I had sent her saying, oh, hi, Mrs. Oakley, I've got TB, I won't be coming in. So of course, the entire year found out within 20 minutes. I then came back to school and they did sort of who could be infected, who can't be, and the people that was in close proximity to me got letters. I then started hearing that my friends' parents were calling in saying, that girl shouldn't be in school. She's a risk to my children. Get her away. And some of my friends said, until you're cleared, I can't be around you. And I'm thinking, great, this is fun. I'm exhausted. I'm only in school for an hour a day. No one was really speaking to me. So I ended up being alone for the month when I was feeling awful. So people say that treatment takes a lot, like finding out people have TB takes a long time. However, for me, I had an excellent team of doctors working on me at the Whittington. Dr. John, my nurses Molly and Mary were brilliant. Initially, obviously, they spoke to my mum saying, oh, she's got to take her pills, but I started to think, actually, this is my illness. I need to speak up. I need to say, what do I do then? What does that mean? What do I do when I get the orange tears, orange sweat, etc.? How do I deal with that? And they started to think, wow, this girl really wants to know what's going on. However, there was one experience at the hospital that leads to stigma where I had to go in for an x-ray. My mum, my sister had to go for an x-ray, but they were in the adult ward, I was in the pediatric. So they put me in a room, had my x-ray, put me back in this room. I was there for about an hour and a half and I realized, oh, I really need the toilet. I was wearing one of the masks. I sort of called the button for the nurse. They come and they're sort of standing outside the door with the little window going, we're not allowed to let you out. And I tried to pull the handle and they're like, you're locked in, I'm afraid. You're going to have to wait till your mum comes to get you to use the bathroom. And I was there for another 45 minutes and it was awful. I wasn't feeling well. I needed the toilet and I wasn't actually allowed to leave. So, you know, that wasn't the best experience I've ever had. And I understand that most of you work with teens who are foreign and don't really understand things, but obviously I'm white, middle class, and I'm from London. I like my education, I like learning, so when I was told I had TB, I did the research, I looked up what it could be, antibiotic resistant, etc. But when people ask me, what would you tell doctors if you could do it all again? What would you advise them to do? And I mean, it's quite difficult to explain how you feel when you have TB, because you can list the symptoms, you can say, oh, my back hurts, but no doctor will ever understand TB unless they have it. So when speaking to teens and adolescents, as you say, they don't like listening to authority figures and they sort of push back. But if you really involve them in their medication, if you try and make it as fun as possible, like I got quite excited about the little pill boxes with the Monday, Tuesday, Wednesday, Thursday, Friday, so I loved using that, it was great fun, and you've got to get them to engage in it. So they actually said, do you know what, we don't give these out often, but have some colourful pills. Here are some pills with some colour, because normally they're white and boring. So I got these quite cool orange pills and a pink pill, and oh, it was quite exciting. And they actually, in the end, my doctor spoke to me more, and that's when I engaged. So my one piece of advice when dealing with adolescents is to actually speak to the child, speak to the person who's got the illness, because it's them that's suffering, not the mum, not the dad. Obviously, their kid is ill, they're not happy with it, but they don't understand how difficult it is to remember to take your pills, to remember that you need to tell people, you need to own the illness. So I think, therefore, if you're going to treat adolescents, you need to speak to them, even though they're difficult, even though they can be annoying. Speaking from experience, I babysit, so I have some 13-year-olds that I say, go to bed at 10. I go upstairs, they're still awake at 1 in the morning. So you've really got to make them understand the illness and engage. Engaging with the illness is the most important thing that you can do for them, because if they're not engaged, if they think, oh, it'll go away, it won't go away, it'll get worse, and they may even die. So you need to engage. That is the one piece of advice I would like to say to everyone here today. And I also want to thank Catherine and Leslie for organising this for me. It's a great experience to speak in front of everyone, to tell my story. So yeah, thank you, everyone.
So if anyone wants to come to the mic to ask questions, I'll just comment that I think this is the highlight of our session, is to have Eleanor talk about her experience. Obviously, she not only speaks very eloquently and very instructively to us about what it's like to be an adolescent being treated for TB, but she's probably one of the most well-rounded and mature adolescents that we've met. We got the chance to have dinner with her last night, and she can talk about anything from venomous snakes to dangerous animals and all of her travels. So really great to have her here with us. Any other questions for Eleanor?
It's all right.
Thank you so much for your presentation. It was really wonderful. My name's Jennifer Furran. I'm a TB doctor from the U.S. My question is, we often think about peers and how your peers could be more supportive. I mean, high school's not a great time anyhow for peer support, but I'm just wondering, what do you think about peer involvement, and how did you talk to your friends about your disease? How could other people your age, you think, have been involved in providing support to you? Thank you.
I mean, initially everyone at school kind of avoided me. They didn't want to speak to me. But when I started, this sounds weird, but I started to laugh that I had TB. I started to say, oh yeah, I've got tuberculosis. Yeah, it sits in your lungs. It's not that fun. And when I started to make them see my side of it, how actually fair enough, I was the only person affected by it. No one else, I didn't get anyone else ill. I didn't drag anyone else into my doctor's appointment, well, apart from my mum, but that was a given. And eventually all my friends started to understand, and now when I tell people and we talk about it, they laugh, they apologize for distancing themselves from me. But until the majority of stigma's gone, I don't think young people who even understand TB, like I'd have friends who go, wait, what's TB? I say, oh, it's tuberculosis. That still exists? Really? That's an old disease. And I'm like, yes, I had it. Until you actually understand tuberculosis, because it's not really taught anymore. Like, I didn't learn about it in biology. I didn't really hear about it until I had it. So I think you need to educate the children on tuberculosis before you actually begin to make them not be scared of it.
Thanks. On this similar topic, you mentioned last night being aware of other adolescents who were TB infected and having had conversations with them. Can you comment on how helpful that has been to you, and whether you think there are particular forums where we might want to get our patients together in order to support each other?
I mean, the only time I actually met TB patients was in the TB clinic. And most of the people I spoke to, there are a few children, but they didn't speak very good English. They were foreign, they were immigrants, and they didn't really understand. So I'd be telling them all this, like, oh yeah, school, and they'd be like, what? You do that, you do this. And there was one boy who went to a state school. If none of you know what that is, it's a government-run school, massive school, about 100 in a year. And when he was diagnosed, they actually put him in his own private room, isolated from everyone. Even when he wasn't infectious, had a mask on, and they taught him in his breaks and his lunch times. And I guess with that, it's quite difficult for me to speak to people about my illness, because no one I know has come into contact with it in my sort of social circle, my family, friends. And I guess if, as you were saying, social media would be a good time to get people speaking about TB online and stuff, but it will be a lot of effort because people are actually scared to admit they have it. My cousin, who was 22 at the time, still doesn't tell people about her illness. Only people close to her know about it. And I think people with TB are actually scared to talk about it, to understand it, to tell people, because they think, oh God, people are going to judge me. Like my mum, she went to a party a few weeks ago and they said, oh, we haven't seen you in ages. How is everything? And she sort of did a chronological events of what had happened. My mum was like, oh yeah, and Eleanor had tuberculosis a few years ago. And I kid you not, they all went, what? TB, really? So I mean, people have got to admit to it before you start forums, and they need to get rid of the fear first.
I think that's a really interesting point. We've talked a little bit about social media. That might be an environment where people have a little bit more openness, it seems, at least from teenagers, to be able to ask each other questions about their experiences on treatment. That might be a really interesting thing to look at for adolescents. Other questions for Eleanor?
Hi, Elena. Thank you for your presentation and for being quite brave, really. I think being young in this environment is quite challenging. I wanted to find out, I think most of the presentations that were done earlier were showing the response of adolescents when they're being told, I would underline told, to take their medication when it's time to take them. What was your experience, and did you have any side effects from your medication?
Well, initially I actually, because my dad had a heart attack the year before, so he was on pills, and he was like, oh, you should take them, we'll be pill pals, like, it's quite exciting, they're fun. So And my sister had a brain tumor when she was younger, so we all knew taking pills and medication for your illness is important. So I never really got side effects apart from tiredness, but the main side effect I got, which made me stand out from everyone, was the orange sweat. So for PE, we had to wear a white Airtex grey skirt. And we'd be running, doing laps, and I'd start to sweat, and my friends would go, "What's on your shirt? Have you not cleaned it?" And I would have big orange sweat stains just all across my shirt, and I would be thinking, "Oh, this isn't fun." Now people can point me out and say, "Oh, look at the orange girl." But that was my only main side effect of TB medication. I reacted quite well to it, and it wasn't actually too bad. Well, apart from the 12.5 pills, that was quite difficult to swallow because I didn't like taking them one at a time. I just wanted to go, right, pills, done, finished. But other than that, that was the only thing I struggled with.
Eleanor, I have one other question. When you had your follow-up appointments, did you have to miss school to go to your appointments? Were they flexible with you, or how did that work?
I mean, my school was actually really, really supportive of my TB. They let me miss as much, like if I needed to go home exhausted, I could put my hand off my lesson saying, "Oh, miss, I'm not feeling well, can I go home?" And they'd be like, "Of course, go home, feel better, come back tomorrow." So when I said I had doctor's appointments, we'd always arrange them in advance. So I'd go to my teacher and say, "On the 15th of October, I'll be going to my doctor. Can you tell me the lesson plan and what I'll need to learn? And then can I come see you if I have questions?" So actually, I did miss a lot of school in total. I think I missed about 2.5 months before big exams, GCSEs, if I don't know if any of you know them. I missed 2.5 months right before my exams, but I actually did really well in them. I got 6 A stars, 5 A's and a B, and that's missing 2.5 months of school. So I guess going to the appointments, I still managed to do the work because I could go home and I would actually do my own work in my own time, which was a lot less exhausting than going to school learning. So missing school actually seemed to be the best course of treatment for me, so I would actually stay in bed and do my work and stuff. And then my mum would drive me to hospital appointments, and I wouldn't actually have to do too much walking and moving, which actually saved me a lot of energy that I would lose during school, so I could use it at home to work.
Other questions for Eleanor? Thank you so much for participating. It was really great. So I think we've heard on a range of complementary speakers about the scope of TB in children or in adolescents, and as young as 10 to 19. From Catherine, we heard about outcomes and management of drug-resistant TB in adolescents, HIV co-infection, and also some of the social considerations and perspective of what it's actually like to be an adolescent on TB treatment. I realized, as we were talking, that we didn't get to some of the other management issues that might come up, particularly management of the TB medications with concurrent HIV therapy, or also birth control and considerations related to reproductive issues in young people. I did want to open things up if people have other questions for all of the speakers that we had today, or any other comments on things that you've seen in your practice with adolescents. I think this is a good forum to sort of share what we've seen, and also, as the gentleman was saying, some of the positive factors that can support adolescents on treatment. I think we've already heard a lot about supporting autonomy and involving adolescents in their own care, respecting their independence and developing autonomy is being very important, and perhaps some importance related to peer influences and potential use of things like social media could be one area to develop, but using the strengths that adolescents have to be involved in their own care.
Hi, thanks. Thanks for a great symposium. They were really great, interesting talks. I just wondered if you would like to comment on the use of incentives and enablers in the treatment of tuberculosis in adolescents, financial incentives and enablers, conditional cash transfers. I'm working on a study in Peru evaluating conditional cash transfers for TB patients, and a large proportion of our population are adolescents. And we observe similar results to your results. The rate of loss to follow-up is much higher among the 15 to 20-year-olds than it is in older adults. So we're evaluating whether or not that improves adherence and improves outcomes. I just wondered if any of you had any experience of that in your practice.
I'll say that I don't know of adolescent-specific studies that have looked at those interventions. I don't know if any of our speakers can speak to that.
There was one study where it was trying to link incentives to adherence.
Do you want to go to the,
So there was one study that was trying to link adherence to incentives, and what they actually did was they had a urine dipstick, and when the kids urinated on the dipstick, if they actually had adequate serum concentrations of drugs, a code would appear, and you could actually redeem those codes for cell phone minutes. So, I mean, I think that's, because we bribe our little kids all the time in clinic, but you can bribe a little kid with a sticker, right? Little kids are cheap, right? So you got to figure out something that actually, you got to figure out something that actually has value to an adolescent. So we've thought about, we pay for the parking for the families, but that doesn't really have a tangible impact for the adolescent. That has an impact for the parents, right? So it gets the parents to bring removes a barrier for the parents to bring their kids to clinic visits. But the adolescent really doesn't get anything at all out of it. They do get out of school, which is sometimes incentive enough for some of our kids. So we've thought about, is it iTunes cards? Is it something else that might be something adolescent specific? But I haven't seen much else in the literature on it.
Sorry, Ian Kittai from Sick Kids in Toronto. Great presentation, great talks. One thing I'd be interested in people talking about is clinical presentation and how that might differ. Certainly, I think there are studies from low burden, sort of high income settings that say there's a lot of extrapulmonary disease, and that may lead to delays in diagnosis. There's a French study. We had a small one from Toronto as well. Andrea's had a big one, so maybe she can talk more about that. But whether that also applies to high burden settings, and I don't know what information there is about that. The other was just a great talk by the last speaker. Certainly in Toronto, our adolescents took 5.5 months to diagnosis sometimes, and it wasn't for want of seeing doctor after doctor. It was lack of clinical suspicion in that setting. So,
I think we can probably have Andrea talk about that, but it's a really good point about recognition of TB not only in high burden settings, but also in low burden settings where we might not think about it. We talked a lot about how it's, to Eleanor's mother's credit that she persisted in evaluating for that. I think, and Andrea can talk about this more, but there's a spectrum of extrapulmonary and pulmonary TB. You see more of the cavitations in adolescents, but also more extrapulmonary disease than you see in adults, but this certainly varies by HIV prevalence in this setting. I don't know if you want to speak more about that.
Yeah, certainly the Houston experience, we have, I think I've taken care of one child who's co-infected, so I certainly can't speak to that from the low burden setting standpoint. We typically think about things in terms of inter and extrathoracic. So a lot of our adolescents have pleural effusions, and I think many of those kids have often repeated surgical intervention prior to somebody contemplating the diagnosis. So one of the questions that I asked Elle when we were at dinner last night was, how long is a white kid who'd never left the U.S. or who was London born and raised, did it take her to make the diagnosis? Because our experience in Houston is if you're a non-Hispanic white, it takes forever to make the diagnosis because the index of suspicion is even lower than it is for our kids from other racial and ethnic backgrounds. The other thing we realized is that so many of the kids who have TB lymphadenitis often had incredible diagnostic delays. They were treated with repetitive courses for strep and for staph. And then, if they got referred to ENT, a lot of times our ear, nose, and throat colleagues would treat them as though they had non-tuberculosis, even though they were a 15-year-old kid who had a number of TB risk factors. And unfortunately, a lot of the stuff that they would start there we've had a couple kids who were started, for example, on rifampin monotherapy by an otolaryngologist. And it just makes a little part of you shrivel up and die when you hear that, right?
I can say that we've seen a similar case in our setting. I don't know if you can comment on the hesitance to start presumptive treatment in low burden settings when you don't have a microbiologic diagnosis, if that leads to diagnostic delays.
Certainly it's not a hesitance that we have on our part. Part of the problem is a hesitation on the part of the parents, because the moment you start mentioning meds, they're doing exactly what Elle did, right? They're sitting there Googling it. And they're Googling stuff on if you give INH to a 70-year-old alcoholic, they don't do well. right? And then you have to talk them down off the ledge and talk to them about stuff that's very pediatric specific. Because even if you go to reputable websites in the US, it's all very much tailored for adults. And very few of those data are actually at all pertinent to the pediatric setting. So you have to talk to the parents about sort of what do you expect, things of that nature, before you can proceed. But we're lucky because very few patients in our area are actually started on TB meds by somebody other than us. Even the patients, when they're inpatients, if they get an infectious disease consult, they're calling myself or they're calling my partner Jeff and they're saying, hey, we have this kid, what do you think? So we're very fortunate because we have a lot of input into when the kids get started on meds in our setting. And I realize that's not the case in places where care is more fragmented.
I mean, just from the epi point of view as well, like the relative paucity of data on extrapulmonary TB in all age groups is incredibly striking worldwide. The impression I get from talking to doctors who work in, very varied settings is that probably the epidemiology of extrapulmonary TB does vary quite a lot around the world. We have a colleague who worked in Solomon's who says he says heaps of like POTS disease and spinal TB and stuff that he hasn't seen in other places. And then you hear really different things from different people in different settings about what kind of profile of extrapulmonary disease they see. But I don't think that's something that's well documented at all at the moment. Do you want to?
So I don't do a lot of work in adolescent TB, but I work in Haiti and India. And I know with our adolescent HIV clinic in Haiti, what we've started to do as a pilot, and I don't know if this would be applicable to TB, but we've started to do peer groups for HIV treatment. So there'll be a group of like 10 or 15 of them, and then there are incentives for the group. So if they're all adherent, then they get, they actually get cell phone minutes, so at least that's universal. But it's worked fairly well because it's like whoever was talking about this psychological whatever. So, I mean, they don't care about what we say, but they do care about what each other thinks of each other. And so that kind of peer pressure, we're trying to leverage the peer pressure to be a positive thing. I don't know in terms of infection control issues if that could be applied to TB, but we've had some success with improving adherence, at least with adolescents for HIV. So I don't know if anyone has done that in any of your settings, either high or low burden, but just something to consider.
All right, Steve, for the final comment, because we're about to get kicked out of the room.
Oh, right, sorry. This is very quick. It's just a reflection, and maybe Liz might want to talk to it about the TB HIV. I mean, from an observation of mortality and TB-related mortality in adolescents, one thing from my experience in the HIV endemic setting, there was in the past a cohort of HIV-infected adolescents who actually had been infected with HIV perinatally, and these children, these adolescents, they came to adolescence with a lot of chronic lung disease, and they got a lot of TB treatment for probably not TB, and they had poor outcomes, and etc. Now this is changing to a group that is growing up now on antiretroviral therapy, and I suspect that that's going to change the situation. And then you've got a different adolescent who's infected during adolescence with HIV. So it seems to me a rather complex thing in trying to work out the relationships in terms of disease risk and mortality. Maybe Liz might want to talk to that as well.
Closing comment.
I think sort of getting at the issues with both TB and HIV in adolescents. TB should be an entry point for diagnosing HIV, and we also see with these perinatally infected children with HIV, a lot of complications from lung disease and things that are not TB being diagnosed as TB, so both issues at play.
Yeah. I agree with the comments that you've made, and I think the one thing that we haven't talked about that's really important is making sure that the adolescents who were born with HIV but have not yet been diagnosed are identified. Many of them do get identified when they present with TB and other severe opportunistic infections. And with those data that I showed briefly, with the 50% increase in deaths among adolescents with HIV, the fastest slope is actually in 10 to 14-year-olds, which is not where we're seeing the most trouble with adherence. And so that is most likely reflective of late diagnosis. So I think looking for those individuals before they become sick and making sure that we reduce stigma to the point where we can get kids tested early for both HIV and TB is critical.
Well, and with that, thank you all so much for coming. It's been great to see so many enthusiastic people here, and please thank all of our wonderful speakers.